Our discussion this afternoon has to do with assets and how we manage those assets. Basically, there are three valuable assets that every individual has in life. You have health, you have life, and general well-being. And you have opportunities that will help you or provide means for you to expand on those assets such that they bring you benefits and returns in the end. And from the point of view of AfriHealth, those are research, knowledge, and value addition to the knowledge and information that you acquire. Then, if you don't do well, or there are queries and deficiencies, you have to have the courage to change the way you have been acting, the way you have been doing things, in order to be able to get better results. And to change, you must have a mandate. And that's where we are starting from. A mandate for change to facilitate effective health action for sustainable health systems in Africa. In the end, if you change that, you will have to change your mindset, your practice, and your ways of habit. And you take charge with courage in order to achieve everything that is possible. In the end, your reward is growth and development in achieving not only the agenda of the SDGs, but gaining health and productive nations in Africa and growth and development in Africa and perhaps the world. To address this, I start from a simple premise. African health systems are not as functionally healthy as could be able to perform at maximum capacity and capability to support the SDGs. The result, therefore, has been failure, national agenda and programs, marginally fair performance indicators, poor system performance outcomes, poor service delivery in almost all major parameters, and poor growth, development, and particularly customer satisfaction. The hypothesis to change this is that we need a mandate to change, mandate for a paradigm shift for change and transformation. To do that, we must identify the causes for our poor performance. We must give tentative solutions for poor performances. We must reverse the trend and achieve effective health action and impactful, sustainable sector development and growth, and finally, effective, affordable health systems outcomes on the continent. First of all, we have to define what we mean by health systems. Health systems are agents or agencies for leadership that serve as stewards, protectors, and facilitators of public interest in right to access health services for health and well-being. To do that, they have to have good governance and management of the assets of the people, namely health, life, and well-being, and they have to have a leadership that balances between leading and serving. They have to be able to manage the material resources. They have to be able to make formulation of good, sound policies, planning strategies for health, so that it is in all aspects of national activity and planning. Then they must provide personal and community health services, public or population health services, health research and development, and where we fail both as professionals, we must advocate We must lobby to create awareness, and we must stop being silent in the domain of national activities. When we do that, then the systems will become facilitators for health to access to health, which means the conventions of WHO, the UN, etc. will be fulfilled. The functions are basically these: personal or individual health care services, public or population and community health services, health education, research and development, health in all national policies, programs and agendas, advocacy, awareness, ownership and responsibility, which we do very little of as professionals, and resource mobilization for health management, material, human or otherwise. The diagram on the right shows how this can be integrated. When we do this, we will have sound policy formulation and implementation methods. Sound policy implementation is the foundation for health systems, resource mobilization and investment and fair budget for health, health facility, infrastructure, and a useful if convenient supply chain. Human resource education and training, forging linkages, partnership, donors, NGOs, and building professional managerial expertise with health professionals by forming think tanks or advisory councils consisting of academia that will advise the Ministry of Health in how to proceed. We must establish beneficial partnerships that will be win-win instead of horse and rider, where the horse does all the work and the rider gets the praise. We must have cabinets and ministers that are knowledgeable enough. Health is the only area in which our politicians do not and are unwilling to appoint the people who are knowledgeable, competent, and experienced. They bring their cronies and put them there, and then, in the end, they mess up the whole system. Conscious awareness of 21st century transformations and taking ownership and responsibility for the system and its results. The health system proclamations have been many. Most of them were crafted without the participation or listening to the voice of Africa. And even when that voice was uttered, they did not listen to us. They told us what we need to do. And worst of all, we are quiet. And we are doing it, and that's why we have failed. Health system proclamations, we have major health development agencies. We have said yes to those. Human resource and material resource mobilization and utilization, we have said yes. Health performance indicators, giving, we have accepted them. Advocacy, awareness, and professional lobby, we said yes, but we have done zero. Ownership, responsibility system for what we do and how we do it and why we do it is very little. To the right, our scorecard. Less than 4%, less than 30%, 20%. Table Mountain Accord, for instance, that says governments must give 20% budget support to the health sector. I looked, and there were only 5 countries that came near. The rest were way out. Poor current status in retention, attrition, and brain flight. 65% awareness, and about 200 claims have been made. 25% in ownership and responsibility. Health system core structures, because of time, I will not go into them, but there are many. We have accepted those also, and we work by them, but we have not done very well. The functional areas of personal services, public health, health education, health for all, and let alone Britain, our former colonial master. So all of these things we are doing poorly, and we have to do better. The challenges and the obstacles are also many, and because of time, I will not read all of them, but you see them and you may have a copy of this result. The scorecard there also is barely fair. The solution, therefore, to all these failures, proclamations that we do not honor, job that we have to do but provide no resources for, and the critical ones that we could do, we let them go because we don't have the courage to say you have to stay and work for the training that you have received. We have to have a solution and some recommendation. And that solution is a paradigm shift. This paradigm shift will produce healthy systems, and the healthy systems will produce healthy performance, healthy nations, wealthy nations, happy growth and development in Africa and maybe beyond. All of this is based on the right to health. Every government has the obligation to generate conditions in which everyone can be as healthy as possible. And to be healthy as possible means to have access, to have safe working conditions, safe potable water, sanitation and health, adequate housing and nutrition. Those are not available, and the health sector has made very little contribution in their achievement. The right to health core, a diagram, definition, dependency, what goes together and what determines it, and the right to health. There are many enshrined in all the international documents, accessibility, yet more than 150 million people globally, that is 2.5% of the global population, suffer financial ruination. In Africa, hardly anybody is available to pay for the health services, and shamefully, our leaders go to India and elsewhere and leave their people to die while they go for health services. Another 100 million, because of the global population, are pushed below the poverty line, and 250 million have no ability or timely access to the services that we have. 200 million people globally suffer from ruination, and most of those are people who are poor, vulnerable, marginalized. The conclusion is that global health care delivery is not yet universally equitable just worldwide, let alone in Africa, because Africa is among the major defaulters on the right to access health. That's the core content. That's the graph. Those are the determinants. The major determinants: accessibility, awareness, availability, approachability, adequacy, affordability, acceptability, affectability, accountability, good quality, durability, transparency, participatory action, and dependability. All of those are very scarce. Over 60% of our population in Africa do not enjoy any of those A's. This is what it looks like. On the left, good health management, the team and the patient dialogue, endless crisis, unable to pursue 21st century transitions, and participating. Our failure to learn lessons from the past will condemn us to failure in the past. 2, awareness of the burdens of failure, reinventing the wheel, plethora failure, national efforts, dependency crisis, etc. Number 3, establish the nature of the paradigm shift, change mentality, create new possibility for effective healthcare systems. Therefore,
and those who had it. They were all specialists teaching the medical school. And those who had had at least a year of training on how to do research and practice it were producing a paper idea. Those who had not done the training, it took them 5 years to write one paper. Yet there's the pressure to do research, publish, so that you can promote it. So clearly, the longer training with good epi skills, good biostatistics, scientific writing, there's no going away. Those are the skills that will help you to deliver on that activity. So I hope the World Bank, I think that GFF was a World Bank program. Hopefully they'll put in money to support universities to train.
My question is to the World Bank. When you engage in academia, are you engaging them directly or through government? We understand that government sometimes, I don't want to use the word bureaucrats because there could be people from government here. But it creates problems trying to engage academia directly so that they support implementation science research. Is there an opportunity for World Bank to engage directly with academia so that the process is smooth and more efficient?
Thank you. Number 3.
Do you think it's in any way doable with traditional training approaches, or would we need different approaches? There's online lab training tools like Labster. I don't know if you're familiar with it. Probably are. I work for a company called Lectori. We have links to 230 histology videos, and I know medical education better than the specific lab technician, etc. training. So my question to you is, to what degree do you think online supported approaches at least are necessary to even stand a chance or not, and to what degree is it doable in this specific topic area?
Thank you very much. Maybe it's devoted to research, and meanwhile it is a very important way to move the science ahead and to make sure that new discoveries are there, and also to make sure that existing discoveries are scaled up. So it is really important to train the Ministry of Health, but I would also say it needs to be part of the whole medical curriculum. And I believe currently there's insufficient investment in training the new generation of doctors in research.
So that's a very vexing question, and it's one which has been discussed quite a lot at the American side of clinical pathology, when some of us have raised, or maybe we don't need to train. Pathology training is now, I think, we're about 5 years if you do anatomical and clinical pathology. So it's longer than most residencies. If you do just one, it can be 3. And I think that's untenable. So people have said that, well, maybe we can have a more targeted kind of approach in African settings. The American side of clinical is sort of against that approach. At least their chief medical officer, because he thinks that it requires such expertise to diagnose accurately that you can't just, give a short shrift and say, that you're good enough to kind of do this. So it's a big dilemma, but I think the tiered approach is one way of cutting out redundancy and not having everybody in every place do everything, and having quicker referrals upwards. I do think we need to, we had a whole symposium at ACP and last year, and some members here were invited by ACP to attend, and it was a very interesting symposium about how to do education, improve the education. What I didn't touch on is, why aren't medical graduates going into pathology in Africa? There's a stigma. There's a lot of stigma. In fact, I have a friend who's a pathologist who said his brother always tells him, don't tell me you're a pathologist, tell me you're a real doctor. And part of that is people associate a lot of pathology with death and the autopsy, cutting up dead bodies, and that's just not true. I mean, I've cut up other people. I don't do that. It's a minuscule part of it. So there's a lot of stigma still. I'm curious to hear if other doctors here agree with that. But there is stigma. We need to get rid of that so that people see it as a viable discipline to go into. I mean, lastly, we have now a huge telemedicine network, and the problem with telemedicine earlier with histologic diagnosis was that these sections were not clear enough to transmit and make an accurate diagnosis. Now they're getting very good with sharp pixels, so it's much more doable. We have a huge network at ACP where telemedicine is becoming much more viable. That still doesn't get past the training. So absolutely we need to do the training and maybe do have somewhat shorter training, but still has to be very expert on. And I think artificial intelligence instrumentation can do some of it. We have it in our setup with some of the hematologic machines do a lot of the sort of basic diagnosis so that you take the burden off the pathologist to have to do very routine kind of diagnosis. So I think it's a mix of a lot of different things that we get there.
Make a comment with regards to the death of pathologists. When at the undergraduate level in advanced countries, anatomy, particularly microscopic anatomy, is commonly taught with the use of anatomics. Now, this student has finished, is now exposed to using the microscope to study human tissue. Though the anatomy is good, but I think it's from the more preclinical level that they should be exposed to at least using the binocular microscope, watching to study slides prepared at least with HRA. The anatomy is there, the prepared slide is there, projected. All those are non-human tissue. That will stimulate their interest to want to go into pathology because of pathology is microscopic anatomy. Thank you.
Thank you.
Andrew Robinson, a public health physician. The paradigm shift, I thought, is fundamental to advancing health globally. But somehow that, and I mentioned it at a previous workshop, that paradigm belongs in communities and patients. If I just observed today all the delegates and what was offered for lunch and what people ate, the amount of saturated fats that were consumed, the amount of excessive amount of protein, and the second speaker mentioned the rise in non-communicable diseases. Obviously in Africa we have communicable diseases of big headache and they're difficult, but there's an epidemic of non-communicable diseases and it can be argued that the prevalence is far higher than HIV, TB, and with the survival of HIV growing with effective antiretrovirals, they'll all get the chronic non-communicable diseases because they're more sensitive to those, largely because of the medication. Now, if health isn't an event, it's something that is dynamic and it changes. Are we all looking at our own health, being our own monitor and seeing, am I being as healthy as I can be at every step? We all slip up every day. We might have a bad weekend and we think, hang on, I'm going to change it. And thank you for the moderator for asking us to exercise. It's the first bit of exercise in the whole day that is offered to us. So fundamental to health is movement and nutrition. We sit here and we have this water bottle, and the Professor Ogunsola this morning spoke about believing in ourselves as Africans. Recognize what we have and what works with us and make it better. The non-communicable diseases in Africa were non-existent prior to the colonial diets being seen as if you are successful, you eat like your colonial masters. And look at the illness that comes as a result of that. The traditional African diet, you saw no diabetes, no hypertension, hardly any stroke, hardly any prostate cancer, very few circulatory diseases, etc., etc. That was on the traditional African diet which our grandparents would eat, and now it's forgotten. Now, as a group of AfriHealth who want to be the change agents, how can we expect that change to happen unless it happens within us? We sit here, we are sponsoring a global multinational for water. One is plus the carbon footprint of it. The snacks are highly processed sweets. Just some comments on should we not reflect, and if we are that change agent within ourselves, to advocate that change in communities and in governments, be far more powerful. It's not an event. I'm not just going to, okay, I'm at a conference, I can let it slip, but is it every day? What are you doing every day to ensure you're the healthiest you can be? And that's what health is. It's a daily, it's an hourly quest for good health, and for AfriHealth to be that change agent, we need to look at ourselves and think, are we doing enough within ourselves to be as effective as we can be? So it's more of a comment, but that paradigm shift is not out there. The paradigm shift is within ourselves to affect that change.
Thank you very much. Thank you very much. I think
that we need to practice what we preach. I've fought a battle with hospitals. I've worked in my own hospital. What they did was the students got a petition together. We had a McDonald's on the medical school campus. So they wrote a petition and had McDonald's kick off. But lo and behold, our own cafeteria serves the most horrible fried foods and cokes and sugar drinks. The hospital I worked in Cape Town, when I was registered Red Cross Children's Hospital, this was as a student like 30 years ago, they had a dietitian who monitored the whole menu in the hospital. No one could eat any bad food. Now that's responsible. Hospitals should be serving good food. Likewise, this is plastic. I mean, thank goodness countries like Rwanda have banned plastic bags and plastic. I was recently in the Arctic and the Antarctic, and the amount of 90% of the seabirds have plastic in their stomach. So I absolutely, fully agree with you that we really need to be thinking more carefully about what we're doing at our conferences without, preaching this without following what we want.
the philosophy of health by Barakai, and about finance and health and research by Shakespeare, and by Continua about pathology in Africa. I would like to join me in appreciating the speakers. Of course, I also to appreciate the chairman, mine, and myself, and Emilia. Now I look to invite the host for any housekeeping.
We've come to the end of the formal sessions today, but there's still 8:15, and we'll try to keep the time so that we can cover the business of the day according to schedule. It's been a wonderful day. Thank you all for your patience and participation, and wish you a very pleasant evening. Thank you.
That session is very informative.
So everybody book your tickets for next year at Sababa.
Please, all pathologists, for any form of laboratory medicine, anatomy, clinical, whatever way, can we get together after the town hall meeting, please? So tomorrow may be challenging because of the schedule. So after the USAID town hall meeting, it should just be about 10 minutes. Yeah, there's a workshop at 7 workshops tomorrow morning, 7 to 10.
Just remind us that for those who are able to wake up early, and I hope all of us will, there are workshops starting from 7 o'clock tomorrow. We end by 8:15, and then we start the regular sessions. Just point of correction that we are starting at 8:30 tomorrow.
Oh, is it?
No. Yeah, that's what we said. It's a workshop tomorrow morning for those who are interested, 7 o'clock, and there are 3 of them. And then this evening, there's the USAID staff position.
Yeah, that's going to start now. Please, the USAID Staff Fellowship Program is new. It's for training in public care. For those of you who are young fellows,
interested in public health, for the mentors who want to listen to this, for your mentees, those in your different schools. This program used to be for U.S. citizens alone. It's just been opened up for foreign, what do we call us? Yeah. So, please just hold on and call those after. I'm sorry, I wanted to make this announcement. It's really very helpful. And it will be available after this daily for people to consult and ask questions. It's an opportunity, it's a very good opportunity for training that is coming to us. Thank you very much. Yeah.
We also have with us UCSF, our colleagues who are sitting here, as well as Ambassador Eric Gooseby. And then we also have Johns Hopkins University and CUGH. Some of you might know about CUGH, I guess. Maybe members of CUGH as well. And the interesting thing about PHI is that it has been implementing fellowship programs for about 25 years, maybe a little bit more than 25 years. Global Health Fellowship programs. Mainly when STAR came about, it was created by USAID and then further elaborated by PHI in our proposal. We wanted to use the learnings of all those years of experience on fellowship programs to help make STAR even better than what those programs were. Although, of course, those were all excellent programs as well. Towards the end of the previous program, which was called Global Health Fellowship Program, very nicely named, tells you exactly what it means, unlike STAR, which tells you nothing. But STAR makes it very possible to make a lot of jokes about the word STAR, which I'll try to throw in here once in a while and you'll groan. The Global Health Fellowship Program, as it was coming towards an end, the staff of that program did a couple of studies. One was focused on employers of people, organizations that work in global health, so employers of people, of global health professionals. And the other one was a study of recent graduates from master's degree programs in global or public health. So in the employer study, they interviewed or they surveyed 50 different employers, and 85% of them said that agreed that academia could do a better job of preparing their students for working in the types of organizations that they run. And this was particularly in the area in non-clinical skill areas, non-clinical and non-technical skill areas. So what were the areas that were most important? Things like program design, management, monitoring, evaluation, communication, teamwork, collaboration, leadership, supervision, research, writing. These are the kinds of skill areas that employers found that when they hired people for the job, they were not quite as good at those things as they wish they would be. It was not things like epidemiology or biostatistics or health economics or some of the more academic type subjects. It was these, what many people would call sort of soft skills of doing the job, but what we prefer to call essential skills or power skills. So this was a very important learning from the previous programs, from these employers and thinking about what had been done with previous fellowship programs. In the graduate study, they learned something similar. 152 recent graduates were surveyed. Of those, about 20%, 21% were not able to find a job. And so when asked what the reasons were, there were two main reasons. One was that the qualifications that were required for the job were not the same qualifications that they had, or that there were too few jobs that required the same qualifications which they had. So it was too competitive. And the second was, again, that there were limitations or gaps in what they had learned in school as far as what was needed on the job. And a couple of areas that the recent grants highlighted was new business development, which is like proposal writing, grant writing, and also some of the IT software-related skills. So taking those learnings, we developed STAR, we have included into STAR a very robust, rigorous learning program, which I'm going to talk about. But first, I'll just tell you a little bit more generally about STAR. So STAR is USAID funded. It's focused on building strong capacity among global health professionals at the individual level by placing those fellows strategically at various different institutions, which could include USAID. It may also be ministries of health. It could be NGOs. It could be academic institutions. And the purpose is to help fill technical gaps and needs that are aligned with USAID mission priorities, but also, and perhaps more importantly, Ministry of Health priorities. The fellows are mostly local nationals from the countries where they're placed, but in some cases they may be from one country and placed in another. And that can include Americans who are placed overseas, but it can also include, as one of the fellows we're in the process of recruiting right now, who's coming from Zimbabwe and is going to be working in Malawi. STAR is a 5-year project. It may continue if we're lucky, but as of now it's a 5-year project. And as I said, it includes Public Health Institute, as well as Johns Hopkins, CUGH, and UCSF. So Mike is going to tell you a little bit more about what UCSF does on the project, and I'll tell you as we go through some of the things that Johns Hopkins is involved in and what CUGH is involved in. Unfortunately, Keith Martin was supposed to be here. He's the executive director of CUGH, and he was going to talk about that. Last minute, he wasn't able to come, so I'll have to do my best. Okay, so this is a graphic which I affectionately like to call the Starship, mostly because it looks like that and because of STAR. See, nobody's laughing. I knew nobody would laugh at that. So basically, it's just a quick snapshot of what the project is about. It's our job to build capacity among fellows and interns, as well as the institutions, mostly the institutions where those fellows and interns work. And we do that by implementing a learning program, as well as providing very strong performance management for the fellows, and by encouraging knowledge sharing and collaboration. The technical advisory group is, I'm going to leave that alone for now because Mike is going to talk about that in his presentation. Fellowships are 2-year placements. They mostly can occur at various different levels, starting with technical advisor, mid-career technical advisor, and senior technical advisor. So depending on what the requirement of the scope of work is or the placement, we set the level, and then the experience, the years of experience and the educational background of the person helps determine what level they'll be placed at. Internships can be as short as 3 months, but tend mostly to be between 6 months and 1 year. And those are for bachelor's, master's, and doctoral students in global health, or those who have just recently graduated. If any of you are interested in being a fellow or intern, www.ghstar.org is where you can go and see the postings. You can also sign up on the listserv, which is what I recommend, and which will enable you to get the available postings in your inboxes. So I talked about the learning program. Here I'll give you a little more details. We did some research looking at, again, first of all, those studies that I already mentioned. Second of all, the larger literature around others who have also studied competencies for professionals. And we came up with 8 core competency areas, which are in the box on the left. As you can see, those are not the sort of technical, academic type skill areas, but more of this, again, what I like to call essential or power skills that are required for most people to be successful in their careers. Dr. Sharon Rudy is the director of many of the previous fellowship programs, and she is often quoted as saying that over her 18 years of experience directing fellowship programs, she's had to fire quite a number of fellows who were not successful. Not once did she ever have to fire somebody because they didn't know their technical area, because they didn't know about HIV, or they didn't know about epidemiology, or they didn't know about biostatistics. She had to fire them because they were poor communicators, or because they harassed somebody in the workplace, or because they had poor ethical values. It was these core competency areas that are the place, is where people have trouble when they have trouble. And of course, not everybody has trouble in those areas, but for those who do. So that's why we have called those our sort of core areas, and we require that every fellow or intern in our program works towards learning in those areas to achieve a certain level on a milestones framework that we've also developed. Now, we don't want to leave out the technical and content areas, so we do have those as electives, and so in addition to the 8 core areas, fellows will choose 2 to 4 technical or content areas. Those are your more sort of traditional subjects. They might be related to the particular health area that you work, like HIV or family planning or nutrition, or they might be more of cross-cutting type skills like biostatistics or health economics or data sciences. But how do we determine what each person will do in their learning plan? It's not the case, so our program doesn't have cohorts of fellows. We don't have 50 that they already have reached a certain level and it's not so necessary, but they would like to go further. They can give us that information at that time. This is also where they can tell us which of those technical and content areas they would like to focus on. And then the third thing is that we talk to the on-site manager or the daily supervisor of the fellow. And we look at the scope of work and the job goals of that fellow, and we use that information to help make sure that whatever the learning program is, it's aligned with the job that they're supposed to do, so that it's not that somebody says that they're interested in physics, but their job is related to managing a health program. It should be somehow related to the work that they're doing, and so we use that as well. So we take those 3 inputs and then we distill out the individual learning plan. And then we don't just then throw our fellow out into the wild and wait and see what happens. We engage with the fellow on a regular basis, on a quarterly basis over time, so that we're checking in with how they're doing in their job and their work they're supposed to do against their scope of work, and how they're doing on their learning plan. We also check in with their supervisors twice a year to make sure that there's agreement from the supervisor that indeed this fellow is doing the work that they're supposed to be doing and progressing the way they're supposed to be progressing on their learning plans. And then another component that we add is mentoring. And mentoring can take 2 different forms. One is group mentoring. We call facilitated group mentorships, where we will group 6 to 8 fellows, not necessarily all who are working on the same thing, not necessarily all who are in the same region, because the idea is to help them meet other people who are working in different areas and to be able to discuss issues with people who are not exactly like themselves. And then there's a mentor facilitator who helps guide them through discussions that are problem and solution based around these competency areas, as well as other need-based areas that come up through those discussions. And then the second type of mentoring is more individual. And that can be called upon at any time. If a fellow is having a particular issue in a technical area, they can request to have a mentor, and we can pair them with somebody that we have a pool of mentors that we're developing that we can pair them with to help them work through those kinds of issues or problems. So the mentorships are there to help reinforce the professional development and growth. They also help to empower the fellows to be able to accomplish what they need to accomplish on the job and to solve problems that might otherwise be difficult for them to solve on their own. It helps them to reflect on their on-the-job learning and other learning experiences, and it also promotes peer-to-peer learning and the building of networks and relationships, professional relationships that we hope will continue even well beyond the time of the fellowship. So that's the fellowship part of it. I told you that there is also an academic partnership part. I'm going to tell you a little bit about that. Many of you work in academic institutions. That's the nature of AfriHealth as an organization. And as such, you may be doing research, you may be working on projects. And you might be doing them alone, but quite often you do them in conjunction or in collaboration with other academic institutions, which might be other institutions in your region or might be institutions in the United States or some other region. And partnerships are hard. I think if anybody who's worked in a partnership knows that it's not always easy. There are problems that come up. And what we want to do is to try and understand better what those types of problems are and how we can overcome those kinds of obstacles. So we did a literature search and a comprehensive review of the literature on partnerships to kind of gain an understanding of what's already known out there, of what works, what doesn't work. And then from that we developed a partnership assessment tool. And we're going to put that partnership assessment tool to work in these STAR collaboration laboratories that we're about to engage in. You might have seen that we had posted an RFA for some mini grants that are to help sort of seed partnerships among academic institutions, where either one institution is from the United States and the other is from a low and middle income country, or two institutions from low and middle income countries, who will come together and form a partnership around, or maybe they already have an existing partnership around some global health problem or public health problem that they would like to do something about, and to work together towards that. We will give the mini grant to those pairings, to those partners, and then spend about a year kind of observing how the partnership is happening, how it's working, what's not working, what is being attempted to overcome the kinds of obstacles that they may face in the partnerships themselves. The paired organizations will be working on some global health problem, but our interest is in the partnership. So that is the purpose of the collaboration laboratory, and we are about to embark on that. The applications are due on August 9th. If you haven't already started your application, it may be too late because that's in 2 days. But I won't tell you it's too late for sure because maybe you're a very fast worker. And if you're interested, again, check out our website. We would have future rounds of this as well, so keep in touch with us if this is something that is of interest to you. And then I mentioned the private sector engagement part of our work, and this is something we're just starting, but we're beginning to talk to a number of private sector companies, corporations, foundations that we think, or we hope, would be interested in the STAR project to join us, to help us to perhaps do things that private sector is much better at doing than NGOs are, or that ministries are, or that academic institutions are. They have their own niche in the global health world, and we don't want to miss out on that. So we are, it's really at the beginning stages, but we are starting to set up meetings and to begin discussions with some of these companies and foundations, hoping that they'll be interested in either supporting us in what we're doing or helping us to expand our view about what needs to be done and to maybe do things a little bit differently. And since this is a new area, actually in any of the areas of the project, we're open to all kinds of suggestions that you might have that would help us to grow and become even better than what we are hoping to be. So that's all I have for you now. And thank you very much for listening. I'm going to pass the mic to Cheyenne, who's going to tell you a little bit about what it was like to be a fellow.
So, Dr. Helsner mentioned that the STAR program is largely based on the GHFP model, our Global Health Fellows program, to I gained technical skill set. My focus was in human resources for health, and the focus on capacity building, specifically focusing on global health technical skills, is a great part of STAR that remains from the GHFP model. And during the Q&A, I'm happy to share my experience on going through the program and the elements like the professional development plan and focusing on scope of work that contributes to learning. And so now I will turn it over to Dr. Humphrey, who will share UCSF's role under the leadership of Dr. Gooseby on the convening and the facilitation of the STAR Technical Advisory Group.
Great.
who is not here via video link this afternoon. So apologies for that. Eric he chairs the Technical Advisory Group for STAR, which is sort of a unique entity in so much as it's there to support the fellowship program in a number of different ways. The STAR program, as David mentioned, includes a number of different elements, and where UCSF's primary role is in this technical advisory group. So what is it? The technical advisory group is essentially a cohort of about 20 global health experts from around the world. We're very fortunate to have two of them here today. So Deborah von Zinkernagel, who has spent her career in global health, up until very recently working at UNAIDS, and Fatima Suleiman, who runs the Drill Fellowship Program in South Africa and is an academic pharmacist at KZN, are two of the members. The role of the TAG is multifold, but our hope is that it can serve as a resource to identify potential fellows, identify potential places where fellows may be placed by USAID, as well as serve as sponsors or mentors to fellows. And moreover, the hope is that this group of global health leaders can connect the STAR network to other global health networks that exist. This is a selection of the TAG members that are engaged and their variety of global health expertises and how that diversity spans the whole spectrum of public health. And so I'm not sure I need to say too much more, except that the TAG is there to assist David in engaging folks like you to try and persuade you that this fellowship program is eminently relevant to your practice and potentially a career advancing move for you. And then ultimately the TAG is there to try and connect the dots between ministries of health in countries that USAID works and the STAR program and the fellows and the missions in those settings. So I'll end there. I don't have too much more to say on that. This is our team in San Francisco. If there are questions, I think David would love to answer them. We also have prizes for people that ask questions.
Leaders on our TAG, and where they're standing, there are 10 times, almost 10 times, the leadership out there outside the room. And so for questions, I think I will try to assist by coming down to the floor, grabbing the mic.
I can do that.
Okay. I'll begin because I am in my next job after the fellowship. So I came in with...
You have thought through about doing fellowships, not just individuals applying, but what with government where they have interns to strengthen that system as a model for capacity building.
And we spent the first year kind of building it up a little bit. We have about 12 fellows that are currently placed in positions. Some of them are in Washington, a couple are in Uganda, and then we have about 15 to 20 more that are in process and will be coming on board soon. Almost all of whom will be placed in different countries, some in ministries of health, some in NGOs, and some at USAID. In the process of sort of developing this program, now, so the format that we have now is the format that is easily, let's say, I don't know how else to say it, easily paid for by USAID. So USAID gets an idea of a fellow that they would like to, or a fellowship that they would like to have developed, and they pass that on to us. We develop it, we find someone to fill the position, and then USAID gives us the money to pay for that. In the process of developing all of this, what you're suggesting has come up. It came up actually in the TAG meeting that Fatima and Deborah were a part of. The idea that perhaps we can have some specialized fellowships or internships, maybe fellowships, because people in the ministries are already in jobs, already working. An internship has a kind of connotation often for being very early in your career, and that's appropriate for some, but maybe not for people who are already in jobs. But having a specialized fellowship where people can stay in the institution where they're working and get some of these learning inputs to help them become better at what they're doing and help others that they work with become better. And it's a model that we're very much interested in doing, but I have to figure out how to get that funded. That's the main thing. So I've started talking to USAID about that, and it's one of the things that we're talking to some of the private sector organizations about to see if we can get interest in from them in supporting that kind of fellowship, which actually would be a lot less costly because we would, in a normal fellowship, we would be paying for the salaries and benefits and everything of the fellow, as well as all the learning inputs. Whereas in this model, where we would be letting people stay in their jobs, but creating the fellowship within the job they're in, we wouldn't have to pay salaries and benefits. That's already part of the job they have. We would only have to pay for the additional inputs. So I think it's a model that is that would be very useful, be very sustainable. We just have to convince the donor that that's something to do.
Presentation. So for those fellowships, do you put out an advert, a call for applications, or they just apply anytime through your website?
So both ways can happen. What happens is that the fellowship position or the internship position is created, and then it gets posted. And so you can apply, or anybody can apply directly for that particular position. But so yes, the internship organization that wants an intern, the funding organization that wants to pay for the intern, and the person who wants to be the intern. And we have to match those three things together, and that's how the internship gets created. Same with the fellowships. So, you're from which country? Nigeria, okay. So, we don't have any internships in Nigeria just yet, but there is one or two fellowships that we are recruiting for. That if you go to our website, I think you'll see them, unless it's possible they've already closed. I'm not 100% sure where they are in the process. But I expect that we will have more in the future.
I saw the three different cadres, like medium, mid-term, senior advisor, and I also saw that you're targeting people who are like 2 years post MSc or people in PhD programs. I just want to be clear. So if you're not in a PhD program and you want to enter maybe at the mid-career, is it not possible to join? Because I think some people will be interested and you have limited them somehow.
No, you do not need to have a PhD to be in any of the categories. So each fellowship that gets developed will have a scope of work and will have its own criteria that's required for that fellowship. So I'll give you one example. The USAID mission in South Africa wanted to bring a fellow from civil society and place them in the USAID office. And part of the purpose of that fellowship would be to help to educate the people who work at the USAID office about civil society and how to work better with civil society, while at the same time capacitating the person from civil society on how to better work with US government. And it was recognized that a lot of the leaders in civil society organizations may not have high education degrees. And so that's not required for that position. So it just really depends on what, on the other hand, if the position is more clinical in nature, and or if not necessarily in terms of providing clinical services, because we won't really have positions that do that, but maybe someone who has to work very closely with clinicians, has to understand the drug and treatment regimens for whatever disease. In that case, we might require that person to have a medical degree. So it really, each fellowship, the degree requirement will be specified based on what's required for the job. Is that, sorry, say
I mean,
my question is a sort of similar thing to the previous question. Is there an opportunity for somebody who is, say,
part of the purpose of the fellowship is to help people grow, and one way that they grow is to kind of make shifts in their career. So yes, but what would happen is there would be a position that is posted, and if that was of interest, you would apply, but you would be competing with many people who apply, and then the committee of people who make that decision would have to consider, all the different factors. So there's no guarantee that, I don't know if you're talking about yourself or some theoretical person, but there's no guarantee that you would get the position if you applied, but you would definitely be encouraged to apply.
so very quickly, are USAID employees, so if somebody is, say, USAID County office or whatever, are they being picked up?
No. With one exception. So if there's a fellowship that is not placed at USAID, is placed somewhere else, and somebody who's at USAID was interested in that, that would be seen in some sort of the same way in which you were just asking, as sort of a shift in their career. That might be, they might be able to be considered for that. But a USAID, someone who's at USAID currently could not serve as a fellow at USAID.
Some of them going to master's programs and all that, to apply for businesses. I'm just wondering whether they can benefit from this kind of program. That's doctors, undergoing their postgraduate training, haven't finished their residency program.
Yes.
Maybe someone in pathology, having done the part 1 exams, would come over and learn some skills. We talked about non-communicable diseases. Some people in medicine or pediatrics or public health could get some exposure. So I'm just wondering whether they can have that kind of opportunity with your program.
Yeah, and I think that's similar to the previous question that one has made a decision that they would rather work more in public health than in clinical services. Then there could be some opportunity for them. It's sort of similar to the lab person who might want to do something a little more in program. Somebody who has been more clinical up till now, but would like to get into public health, this could serve as a potential stepping stone for them to do that. 2 more questions?
Maybe together, so we'll ask the final answers. And then before, did you have a question? Okay, any other questions?
Good evening. I'm Ken Delby. I just wanted to ask, are those who are already on another program, are they eligible? Maybe another fellowship program? And they are still in the process. Is there any issue with conflict of interest? Are they eligible to apply? That's just what I wanted to know. Yes. Thank you.
Yeah, I don't think there's any issue with that. And then this might be your next thing, but there's no issue about transitioning or moving to our fellowship program after you've already been in a different one.
Okay.
Now the list going on.
Okay, yeah, if you can sign up on this list, if you want to let us know that you were here. Please go to www.ghstar.org, get on our listserv. And I'm here through Friday, so if you want to catch up with me and ask any other questions, And I also have, some of you I saw have some cards that give some more information about the program. I have more of those if you would like to get those. So thanks.
And if you have any stress that you need to work out,